And we'll have a bit of a panel. Brad, and is Archie here? Archie?
Yeah, he's over.
Where is he? Ah, there he is. Okay. Okay. Oh, are we missing a chair? So before we get started, I just want to mention that we do have a website, Brandon. Thank you for mentioning that. It's www.aya.usc.edu. I'll read it again, www.aya.usc.edu.
It's on the wall, too.
And there it is, okay. And you'll see a lot about our program. You'll see about some of the national resources that you've heard about today. You'll see the pictures of the various people that we have on our program staff and information for patients as well as healthcare providers. It's for both purposes. And then you can our Twitter handle is at aya.usc, and then today, of course, we want you to use the hashtag Dave25 on Twitter for input to us. So we're open for questions, and I just want to start off by asking one question. It's really for the whole panel, and that is, if you were to choose your priorities, what do you think are the most critical areas of data that we need to be trying to generate at this time regarding the AYA oncology problem and program? So I'll just go down the list here. Why don't I start with Brandon, and we'll just then go to Brad and Archie.
Well, it's a bit of a loaded question because as you already heard this morning, many of us think that gathering data around the AYA problem is actually one of the most important issues. And frankly, this goes everywhere from questions like, where are AYAs being treated? We sort of have a sense of, well, the minority are treated at cancer centers, but we don't actually know exactly where they're treated or with what they're treated or how that affects their outcomes. I think the second real category is data from patients themselves. So this is actually a patient population that's often very eager to give back, and they're already savvy in social media platforms where data sharing is possible. And that's an area that is actively being explored by some of the institutions and programs that we're all involved with. And then the third really is basic science, that as you heard, when Archie shows the graph of these are the cancers that occur in this age range, well, why? Why does testicular cancer happen in 20 and 30-year-old guys? We need basic biology to understand a lot of those.
Brad?
I think we're now in this era of patient-centered care. I think part of what that means is people spend a whole lot less time in hospitals. They're discharged quicker and sicker. So much of care is now falling on the shoulders of patients themselves, family members, and a lot of that can be real stressful. And we're talking about a population of young people who have very limited coping mechanisms. So we're really, sending them back into their homes and telling them to take care of themselves the best they possibly can. And yet not necessarily giving them enough of the support and the supportive types of resources that could contribute to that. So I think there are models of self-management that have been applied in other areas of adolescent medicine. We look at juvenile diabetes management, asthma management. There are a lot of tools that have been tested and have an evidence base behind them in terms of how young people can maintain independence while adhering to the protocol, whether it's doing their hemoglobin test on a daily basis, taking the medications at home the way that they're supposed to. So I think there's a great opportunity for applying some of these evidence-based interventions in other adolescent areas and seeing how they apply in cancer.
Arch?
I agree with everything that was said by both Brandon and Brad. But I think that it is a loaded question in terms of what you mean by priority. So let's say near term, like tomorrow, and locally. I think your number one priority ought to be start your clinic on Monday, but then find every young adult and older adolescent in your neighborhood in Southern California and get that army together to support each other and do what's been tried to do nationally by I'm too young for this stupid cancer, but it really doesn't have a local base. So, and some of you in this room, I mean, I'd go out and network and pull you together. That would be a fact-finding mission to find out who they are. In terms of long-term, there's two. I agree totally with Brandon's statement, but I want to add something to it. That we don't have the specimens from young adults with cancer in our research laboratories to study. I didn't say that during the presentation. Not only are they the lowest proportion on clinical trials, but they have the fewest specimens to do translational research, to take them up to the lab upstairs and try to figure out what's different. So getting the data on where those specimens are and what could be done, we tried it a few years ago with Livestrong and really failed. That, I think, is a potential university-wide, do it throughout the entire California system and figure out what specimens you have. In terms of, to me, the highest priority right now, because of what we're trying to accomplish nationally, it's in front of us every hour, is health insurance. And I think if you go to the Institute of Medicine and look at their proceedings, which are not only videoed, available on their website, Institute of Medicine, and then AYA, but also all the slides, you'll see some data on what was predicted 2 years ago to be 4,000 persons between the ages of 19 and 25 had new health insurance that they would never have had based on the Affordable Care Act, because it expanded that age of aging out from 18 to be on your parents' insurance until 26. There were 4,000 in just the first 18 months of the ACA of new young people diagnosed to have cancer in that age group who wouldn't have had insurance, a benefit of the ACA. We updated that for the Institute of Medicine. It's now 9,500. It's probably even greater because that was 2 months ago. 10,000 young people are covered with insurance that they wouldn't have had, and they have been diagnosed with cancer. That's the estimate. Well, you know the rest of the story in terms of what the Affordable Care Act is trying to do at this point. I think the data exists to find out how many of the 106,000 people who are now on a health insurance plan they wouldn't have had. And California leads the way with 10,000 more than any other state. That's 10% of the total. Washington is second. Kentucky is third or fourth. I can't remember the other states. Oregon should have been much better, although we're just doing it by paper. Get the data on those 706,000 and find out how many are AYAs younger than 40 who now have health insurance, who wouldn't have had it, and if they're diagnosed with cancer, and in 1 in 41, 1 in every 44 actually, 1 in every 44 persons between the ages of 15 and 40 will be diagnosed to have cancer in the United States. So if they're insured when they wouldn't have been because of the Act, despite all of its problems, there's data that speaks for itself.
I'm glad you mentioned that. So I want to encourage the audience now to use the microphones on either side and ask our panel questions. We have a great cross-section of people here from a variety of different areas and disciplines. I want everybody to feel that they can ask questions and participate. I think we'll start... Chelsea, you have a question? Why don't you start with
Brandon,
you?
You spoke a lot about the AYA programs that are out there and up and running. I assume most, if not all, are based at academic centers. Maybe if you could enlighten us a little bit about those programs, and for those that are based at academic centers, if you have thoughts about how we can better engage the community and community oncologists. As we kind of alluded to, we think that, or know, most of our AYAs are treated in the community, and how can we kind of bridge that gap when these programs are based at academic centers without kind of creating some of those turf wars between academic and community oncologists?
Yeah. It's a great question. So you're right. Of those 20 respondents, they were all affiliated either completely or very directly to an academic medical center. I go back and forth, but my current thinking on this is that I don't think that we're likely to have a major impact in creating AYA programs in the community until we do sort of my concluding slides, which is we need to develop the metrics that show not only that a program can have outcome differences in terms of survival or psychosocial or whatever, we need to be able to demonstrate it, and specifically what components of those programs are making those differences, and I think not until then are we really going to be able to translate it to the community. Most community practices are independent businesses, and the reason that these programs are popping up in academic medical centers is because they have resources and philanthropic foundations to make it happen. If you're a private practice of 7, 8 people trying to make a living out of oncology, the chances that you're going to put a bunch of resources aside for what is still, obviously intuitively important, but not necessarily proven interventions, I think is a tough sell.
Can I add to that, Stuart?
Yes, sir.
I think you said it, Brandon, but I didn't really present it, that there are more young people who remain in the private sector in the community private practice than any other age. So the approximate number is 90% of AYAs between 15 and 40 with cancer diagnosis are not referred to an academic center. The average across the country for all ages is 80% above the age of 30 or 40, and for children it's 90+%. So the group that has the least number of referrals to your place is this AYA group. So that's the other side of the problem, that you really got to get them. But I would do what Brandon said and just focus on your program, because if you build it well, the networking that goes on in this age group, they'll get there. They'll find a way. They'll move. So build it and they'll come.
From an on-the-ground standpoint, I can say, having run an AYA program for a while, I feel like I have pretty good relationships with many of our community oncologists, and really those have been built out of anecdotes. They've had a young adult patient in crisis, and then that's when they found the AYA program. It wasn't because we had clinical trials available or because we have something. It's because here's a person who lives on the street, has no insurance, really terrible stories, and then they see that when we pull together an AYA program and can address some of these issues. And then the second piece of it is that we run a consult service. So I make it pretty clear to my community partners that, that young person who's likely going to do well with their cancer in terms of survivorship, we're not going to steal that patient from them. We would love to give insight into how to manage the patient. But they're still going to go back, and the chemotherapy revenue will still be theirs, and et cetera, et cetera.
I was just going to add that I think, Brandon's point about identifying the components that are critical. If we have the data that suggests that, for example, that connection to a peer support program is associated with greater adherence to therapy. Well, obviously in a community-based setting or a private oncologist's office, they don't have access to that, but if the data suggests that that's available, certainly that doctor can be referring that patient to online internet-based programs, programs like Immerman's Angels, where they match patients with survivors to provide peer support. If we have the data that shows those things are helpful, then that can be translated, I think, into community.
I want to add something else, Stuart. Sorry, I just thought of this, but you can do this better than any other state system, including Texas, which has a larger university system than you, and is the only other state that could compete with your system. You have a single institutional review board covering all 5 major medical centers. You could start a program, a protocol, clinical trial, and rapidly open at all other sites faster than, including Texas. So I think the clinical trials possibility here is really pretty striking.
Thanks. I think having had some experience in trying to spread this effort to the community, I think it's education, 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 in addition to everything else that you all said that's really important. Educating the community physicians to oncologists to what is going on in this field, because they still lack a lot of information. I think once they understand the issues and what can be offered, I think that's the key to getting more participation as well, and to trying to overcome some of the turf-related issues. The other thing is that the hospitals in the community are often organized in large hospital groups. A good example, for instance, is the Providence system, which really extends up and down the West Coast from Washington down to California. And we've been working with one of those hospitals, and they've now decided strategically to have a Western or a Providence-wide committee to determine their protocols for cancer. treatment throughout the Providence system. This is, and we've talked with the person who's going to chair that, this is a wonderful opportunity to get AYA protocols and the AYA issues into a large community system, which if it works and is adopted, could be a model for the rest of the country.
Well, then don't forget Kaiser Permanente of California, Oregon, and Group Health in Washington. You can do the same thing with that.
Kaiser's another, absolutely. Yeah. David, question? Sorry to hold you up there.
Great presentations, thanks. I learn something new every time I hear you guys speak, so thank you for that.
So do we.
Yeah. That's good. I think this question is mostly for Brandon, but Brad also, and Archie, feel free to chime in. I guess I wanted to ask about the topic of matching what we provide with what our patients want. So, Brandon, you spoke about, identifying some priority services like fertility and information provision or education. Do we know how well those align actually with, what is in the literature about what adolescents and young adults feel are important? Could you speak to that a little bit?
I think we have a little bit of information, but I think it's fairly scattered. I can tell you that most programs, including ours, try to do patient focus groups and surveys to understand and better match. But I think it's a pretty difficult balance between, what we think a patient needs and what they want or need and what we can pull off. Brad, you probably know more data, though, about what patients say. I mean, we've done some surveys on that.
Well, I think what they oftentimes say is, I don't know what I need. I don't even know what questions I'm supposed to ask. So I think there is a gray area there where it is incumbent upon us as the clinicians to at least raise certain issues that are sometimes uncomfortable, like the issues around talking about sex or talking about infertility, where we've seen great advancement. But being able to do that has involved training and educating providers on how to have those discussions, how to raise those issues. I think there's a great opportunity in front of us in terms of developing this notion of survivorship care plans. And I don't just mean survivorship care plans in terms of transitioning from treatment to off treatment, but actually sitting down with patients and developing a plan of action with them on how to deal with cancer. So we can raise the issues that we think are going to be important for them to think about. They can also raise the issues that are important to them, and then in cooperation, we can lay out a plan. We can provide resources to them based on what it is that they're identifying as important to them as well.
As I think about it, one great example, real practical example of this is you might ask, what do you need? And the answer might be, I need, psychosocial support. My institution's initial response to that is, fine, we're going to create an AYA support group. And we have one. But it is the vast minority of patients who want to go sit in a room with a social worker and discuss their psychosocial problems, right? They want to go to a more social event where their peers are hanging out. And guess what? They're still going to talk about the same psychosocial problems, but they're going to do it on their terms. So that's it. There's a big challenge still, not only in sort of assessing what it is they need and want, but how are we going to deliver it? And oftentimes, in an example like that, it requires the AYA program or the institution behind it to partner, right? So we're not going to host, pub nights. As much as I'd love to. But we might find a partner organization who actually would and could.
Yeah, I think one of the somewhat surprising things that came through the surveys of what AYA patients want was things like camps and social events. I think this came out, just places where they can get together and talk among themselves. And, on the pediatric cancer side, we've seen this in the adolescent populations that have gone to those sorts of things. They actually gain much more from their interactions together without structure, without some professional sort of structuring it, and talking with each other and feeling like they're not isolated anymore and have a chance to talk about these issues they haven't been able to talk about to other people, including their parents. I think it's one of the most effective techniques for that as well. There was a question.
I'll just add one more thing.
Go ahead, please.
I'm thinking of, Clint Eastwood's line in one of the Dirty Harry movies is, "A man must know his limitations." And I think I apply that here to institutions and providers in that we got to know what we do really well, and we should do what we do really well. But we should also recognize what we don't do and might be better left to some other group, agency, a vetted or reputable agency or organization that can do it. What we've seen in the adolescent young adult movement, more so than I think in any other area of psychosocial support, is that it's adolescents and young adults themselves who went out and formed the groups, the online groups, the programs, the projects, the mobile apps that young adults are going to, I think because they recognize they've been created by other young people who get it, who've been where they're at. And, it may be, supporting those folks out there who do that type of support really well, and then making sure our patients get funneled to those areas when appropriate.
We're going to hear from one of those a little later, Heidi Adams, who actually started the first online effort with Planet Cancer, and it's a great example of what you're talking about, Brad. Just before we get to your question, there was a question from the audience about what it would take to create a Western AYA Oncology Alliance, and what would be both the how to do it, what are the obstacles and what the challenges, as well as how we might do it. Brandon, do you want to take a shot at that? Any of you want to take a shot at that? I can comment too, but I'd like to hear from all of you.
Well, I guess my first comment is I'm in. It sounds awesome. This is a brand new field. There are so many opportunities. So you take a look at an idea of a Western alliance, and you could say, well, okay, what are the goals of that alliance going to be? I mean, honestly, it could be banking specimens. It could be clinical trial design and enrollment. It could be these shared assessments of what do our patients want and need. It could be a coordinated fundraising effort because these programs are expensive and hard to maintain. I mean, there's a ton of opportunities there. So,
what I can tell you is that in Michigan, University of Michigan is part of what's now called the Big Ten Cancer Consortium or Cancer Alliance. I'm not too familiar with it, but basically they've taken the Big Ten, which is the athletic organization of all these institutions, and now I think have used that same infrastructure to now coordinate alliances among cancer researchers and cancer care providers. So maybe there's an example where you already have an infrastructure that's in place.
So you're suggesting we have the Pac-12?
You have your Pac-12
alliance. Okay, I got it.
And you could actually think about using the Pac-12 organization and their infrastructure.
And all the young adults in their athletic
sports programs have been interested in supporting cancer. I mean, they're always breast cancer, but no, we've done that with baseball, but in a limited way during the Cure Search years.
Right.
No, that's a really Pac-12. The other point I would make, I agree with Brandon in most of his suggestions, but I think there's also nationally now a intergroup effort among the cooperative groups that David Fryer and Chuck Blanke are putting together. So a lot of the issues of clinical trials and specimens, I think, probably come under that rubric rather. They had their first meeting in the history a couple weeks ago in Cleveland, or was that last week?
Last week. Yeah.
Last week in Cleveland. That means all the cooperative groups, of which there are now 4, just 4 used to be 10 or 11, had their first AYA meeting. I don't know if you're going to cover that this afternoon, David. You will? Fine. So you hear about it then. So I don't know if I would go that direction. What I'd rather do is take the programs that are in existence. That would be Seattle, Portland, here, City Hope, and then Orange County, and get them together and share ideas out of networking. I would have a coalition initial meeting. What would you call that?
I think that's what's being suggested.
Brainstorming.
Well, we'll have to absolutely have to have some discussions about that. Last question, I think, before the break.
It's been wonderful. Started a lot of ideas and things, and I'd like to run one of them by you. You talk about the gap between the pediatric and the existing oncologists, and getting them together, and the conflict with turf wars. And turf wars really comes, funding. If there was plenty of money, there wouldn't be any turf wars. So it's a matter of getting the funding. And then something else that struck me, you mentioned how medicine this day is being pushed back to the community for them to, for patients to take care of it from home with the internet. Let the internet help you, and so if the AYA population can help develop tools, a tool for the broader population to bring the funding to the AYA, not as taking away from one or the other populations, but as the champions around some new tool that would help individuals in their homes interact and get better health care. I mean, it seems to me that population is the perfect population to do that. My daughter champions texting, and she taught me how to text and these kind of things. And
I need her help, actually.
yeah, and texting is a perfect example. It's something that allows me to communicate in a new way, and that AYA group has that to offer in terms of bringing the health benefits. Gentleman Red Tie from Michigan touched on that just a few minutes ago, but I'd be curious in your comments on how you can use the new grouping to bring in funding for the new kind of medicine.
Yeah. Well, this is a very good question, just the whole area of electronic approaches, so maybe we'll see.
Great point. You're right on, and there's people out there who have wonderful ideas that they want to go out and test, to conduct some of these ideas under, within auspices of research, so we can show that there's evidence that these things work. We're still, though, at a point of educating those funders of research that the AYA population, needs this focus of research. When we write our applications for research studies, again, we get caught in the same thing. Well, do we go to a body that funds pediatric work, or do we go to a body that funds, adult work? I've got a great idea for a survivorship care plan to range from the ages of 15 to 29. Well, I can't go to the NCI because the study eligibility only goes down to age 21. And then I've got a foundation I want to apply to, but they're only looking at applications for people between the ages of 18 and 21. So I can't fully cover AYA in either of those funding sources because they're still living by that old convention of either pediatrics or adult. So we've still got a lot of effort to put out there to even convince funders, and that's why the NCI meeting and the IOM meeting this past summer was so important, because I'm hoping that what comes out of that are opportunities for research funding that will cover that AYA group, and then we can test out some of these ideas that you're talking about.
So I can tell you briefly about the effort of Critical Mass. You've heard a little bit of that mentioned. So Critical Mass is a nonprofit organization that grew out of a program from Livestrong. And part of the reason it grew out is it's a coalition of over 150 organizations that span from medical institutions to professional societies to advocacy organizations, each of whom have tools, programs, et cetera, that deliver services to young adults. So to get to sort of your, this is the population to build tools, the main objective for Critical Mass is to build a web-based online resource where all of those things can be shared and searched. Sort of a modern age repository or clearinghouse for these resources. As part of that effort, to sort of centralize, where do young adults go? Well, they go to Critical Mass, and that's where they're going to find the program at Children's Hospital LA and USC. That's where they're going to find Imerman Angels. It also gives an opportunity to actually gather some information or data about the people as they're searching. And giving them the opportunity to actually give more of their own data and information. And ultimately, the plan for that is to build a registry out of it. So I think there are those kinds of innovative ideas that many of us are trying to pursue.
That's a really great point for us to conclude the panel discussion. I want to thank our panelists. I do also want to mention, by the way, that this symposium is being videotaped, and the symposium will be on our AYA website for any of you to go back and look at, and as well as to encourage any of your colleagues who weren't able to come to be able to take advantage of the great stuff that we're hearing today.